Our next speaker is a well-known authority in the field here in pediatric nephrology. He is Dr. Mohamed Al Riyami, a senior consultant and head of pediatric nephrology, Department of Child Health, the Royal Hospital, Muscat, Oman. And he'll speak to us about genetic insights in patients with steroid-resistant nephrotic syndrome. Thank you, Dr. Riyami.
Assalamu alaikum.
Alaikum salam.
First, I would thank you for the introduction. Also, I would like to thank the organizing committee for the invitation. My talk is about genetic insight in patient with steroid-resistant nephrotic syndrome. So the outline of my presentation, I will talk about the difference between steroid-sensitive and steroid-resistant nephrotic syndrome, the importance of glomerular filtration barrier and podocyte. I will talk also about genetic mutation in the gene encoding podocyte-associated gene, and discuss, also I will discuss one case, and finally I will talk about our experience at Royal Hospital, and then conclusion and take-home message. As you know, the most common nephrotic syndrome in children is steroid sensitive, about 85%. This patient, they will respond to steroid within 4 weeks, and they have good prognosis because less likely to go to renal failure. And some children, we may need to do renal biopsy in certain situation, and the diagnosis, the pathology usually minimal change disease. On the other hand, steroid-resistant nephrotic syndrome is the patient who are not responding to steroid after 4 to 6 weeks. It can be related to the immune dysregulation due to circulating factor of glomerular permeability. And this timetable showing us the proposal permeability factor which can cause nephrotic syndrome. There are many factors, but until now still under research. We cannot blame any of these factors. The monogenic, the steroid-resistant nephrotic syndrome, the other type is monogenic, which is due to mutation of one of the gene encoding podocyte protein, which lead to structure anomaly of glomerular filtration barrier. They have not good prognosis because many of them, they progress to end-stage renal disease. But the good thing, they have low risk for recurrence after transplant. And most histopathology, if biopsy done, is focal segmental glomerular sclerosis. This slide showing us the comparison between genetic compared to immune-mediated form of primary steroid-resistant nephrotic syndrome. Genetic form less frequent, about 30% compared to immune-mediated. Post-recurrence is not occur in genetic compared to immune-mediated, but the genetic one most likely, I don't know how to use. Genetic, most likely they will progress to renal failure fast, but immune-mediated, they have 2/3 of them, they may respond to immunosuppression, and only 20% they will progress to renal failure. This slide showing us the glomerular filtration barrier, which composed of 3 layers. The inside, the endothelium, fenestrated endothelium, in the middle, the glomerular basement membrane, and the outside is the podocyte. The podocyte, it has a process, tertiary and foot process, and between the neighboring podocyte, there is a gap, it's called slit diaphragm, which is composed of multi-protein junction structure. You regulate the podocyte function, and also regulate ultrafiltration molecular. The identification of the gene responsible in the expressed in the podocyte make the podocyte a center for the central steroid-resistant nephrotic syndrome pathogenesis. With the discovery in the slit diaphragm protein like NPH1 and NPH2, Then with the linking analysis and the whole sequencing, now we have more than 50 genes implicated in the pathogenesis of steroid-resistant nephrotic syndrome. This is again the podocyte. You can see a lot of protein expressed in different parts of the podocyte. It can be expressed in the slit diaphragm, in the cytoskeleton of the podocyte, in the mitochondrium, also in the nucleus. And if one of these gene or protein is abnormal, the patient can present with steroid-resistant nephrotic syndrome. The most common genetic is NPHS1, which is causing congenital nephrotic syndrome. Then the NPH2, which is expressed the protein podocin and cause childhood nephrotic syndrome, but also can be seen in adult form. Also WT1 also can be one of the cause of nephrotic syndrome in children and adult. And laminin beta-2 variant also seen in, which is protein important in the GBM and also in ocular muscle. And the patient can have what's called Byerson syndrome. So they will have renal involvement plus eye involvement. Some of the definition, if the patient present with steroid-resistant or nephrotic syndrome in the first 3 months is called congenital nephrotic syndrome. If they present between 4 to 12 months is called infantile nephrotic syndrome. More than 12 months is called childhood nephrotic syndrome. And then adult onset steroid-resistant nephrotic syndrome. The most common cause of, the most common gene in congenital is NPHS1, but in childhood you will see other gene like NPHS2, WT mutation. In adult you see another gene also important like TRBC or INF2 gene. And it can be inherited as autosomal recessive, usually seen in younger age, earlier age, and usually can be isolated or associated with multisystemic disorder with high penetrance. And also the autosomal dominant is seen mainly in older patient. It can be incomplete penetrance, and the patient may be asymptomatic. And the frequency of genetic cause of steroid resistance is decreased with age. You can see in the first 3 months the cause of, as a genetic cause, about 75 to 85. But in older patient, in 13 to 17 years, only 11% of patients they have steroid resistant because of genetic cause. This table showing us possible hereditary of nephrotic causing the disorder, hereditary nephrotic syndrome. It can be present as early onset nephrotic syndrome and usually inherited as autosomal recessive, late onset nephrotic syndrome, which usually inherited as autosomal dominant. Also mitochondrial disorder also can present with nephrotic syndrome. Also, there are many many syndromic causes of steroid-resistant syndrome, like Denny-Drash, Fraser syndrome, Schimke syndrome. So there are many also syndromic associated with nephrotic syndrome. This is international cohort study of 526 from about 1,800 family on whom single gene was tested. And in this study showing that patients who present below 25 as steroid-resistant nephrotic syndrome, about 30% of them, they have mutation. And 85% of children who presented in the first 3 months and 66 who presented in the first 1 year, it can be explained by mutation in one of the 4 genes, NPHS1, NPHS2, laminin beta-2, or WT1 mutation. This is a case, this is Al-Muzun. She is a 12-month-old girl presented to Ibra Hospital with periorbital edema for 3 weeks, then referred to Royal Hospital for further evaluation. Family history, she has 2 other cousins with the same problem, with focal segmental glomerulosclerosis. At that time, both of them were in dialysis. But recently, one of the patient is already adult, had kidney biopsy. Now he's under our adult nephrology colleague. Lab investigation showing proteinuria, serum albumin was high. She has high cholesterol and normal renal function. She also had hypothyroidism, ultrasound showing large kidney with increased echogenicity, and echo show mild aortic stenosis. Also, her cousin, both of them, they have aortic stenosis. So the genetic test would show homogeneous missense mutation in NPHS2 gene. So she was diagnosed as autosomal recessive familial focal segmental glomerulosclerosis. She was treated with ACE inhibitor and thyroxine, and in last follow-up, she was at 3.5 years. Still, she has normal GFR. Her serum albumin was still low, but she did not require albumin infusion. So NPHS gene mutation is inherited as autosomal recessive, usually seen in early childhood. Can present also as congenital nephrotic syndrome, but in our patient, no one with NPHS2 present as congenital nephrotic syndrome. They present as infantile or childhood nephrotic syndrome. Kidney biopsy usually will show focal segmental glomerulosclerosis. They have rapid progression to end-stage renal disease, but less likely to have recurrence in the kidney transplantation. So what is the workup need to be done for patient with steroid-resistant nephrotic syndrome? You have to look for other causes, like secondary causes of steroid-resistant nephrotic syndrome, especially viral infection, like Barrow B19, CMV, hepatitis, HIV, SLE. We have to also consider highly genetic form. So we have to ask for consanguinity, family history. Already Dr. Saja and Marwa mentioned about importance of this to ask about family history and for proteinuria, hematuria, CKD of unknown origin. Also, we have to look for extrarenal manifestation like deafness and nail and knee abnormality in case a patient with nail patella syndrome. Also, physical examination to look for ambiguous genitalia and dysmorphic features, neurological examination, and ophthalmology and hearing assessment. You may need to do also investigation for sibling, like to look for urine analysis for protein and blood. So these are some of the extrarenal feature, nail hypoplasia and nail patella syndrome, eye abnormality in Byron syndrome, ambiguous genitalia in patient with Denny-Dry syndrome, skeletal dysplasia and immunodeficiency in Schimke immunoosseous dysplasia, glowing white syndrome, which is a rare, but it can be seen with steroid-resistant nephrotic syndrome. They will have dysmorphic feature and abnormal MRI brain. So why important to do genetic for steroid-resistant nephrotic syndrome? It is needed to know the renal outcome because we mentioned that the patient with genetic, most likely they will progress fast to end-stage renal disease. Also important for genetic counseling to give the parent about the next pregnancy, risk of next pregnancy, also for pre-implantation marriage. Also, this patient, they will not respond to immunosuppression, so you need genetic to stop to decide about immunosuppression. Some patient with some form of genetic disorder like coenzyme Q10 synthesis problem, this is mitochondrial disorder. This patient, if you have the genetic, you know the diagnosis, you can start this patient with coenzyme Q10, and they can respond to this medication. Also, you need to know the genetic to decide about and to know what is the recurrence after transplant and choosing appropriate donor, because the patient with autosomal dominant, high risk if you take donor from the relative, they may have higher risk for recurrence in both the donor and recipient. So very important to do genetic testing. So if you have some limitation, you may only do priority for certain patient, like patient with positive family history, those with extrarenal manifestation, those with going for transplant, but no need to do genetic for secondary resistance. So if some patient they have initially respond to steroid, later on become resistant, this patient most likely they have immune dysregulation, not because of genetic, so no indication to do genetic. And this patient, they have high risk for recurrence after transplant. How about, do we need to do biopsy for this patient? If you have genetic, you can do it within short time. No need to do biopsy. You can do straightforward, go to genetic, but if it is delay, you have to do biopsy, especially for the diagnosis of certain conditions like DMS, diffuse mesangial sclerosis, because this patient, if they have WT mutation, they have high risk for malignancy, like Wilms tumor or gynecoblastoma. So they need screening with ultrasound every 3 months or to 6 months until they reach 7 years. Also, you need to evaluate the kidney for kidney damage, like sclerosis or IFTA. Also, following CNI, some patient with steroid resistant and given CNI, after 2 years of CNI, you have to do kidney biopsy to assess for nephrotoxicity. Other also, you have to exclude other cause of glomerular disorder that cause steroid resistant nephrotic syndrome, like IgA nephropathy, membranous nephropathy, C3GN, SLE, and Albert, as Dr. Seja and Marwa mentioned, also to exclude TMA. The most common pathology in steroid resistant is focal segmental sclerosis, but you can see also minimal change disease. You can see diffuse mesangial sclerosis. Now I'll talk about briefly about our experience at Royal Hospital. This is a study recently published about genetic analysis and outcome in Omani children with steroid-resistant nephrotic syndrome. The aim of the study to know the causes of the genetic in these children below 13 years old over 15 years period. It is involved 77 children from 50 different families from over Oman. We used targeted sequence combined with next generation sequencing approach to form the genetic, the molecular diagnosis. This study done in collaboration with the Pediatric Nephrology Unit at Royal Hospital, our International Genetic Center, and Newcastle University, UK. This table showing us the clinical feature of study patient with steroid-resistant nephrotic syndrome. There are 77 patients, most of them female. The mean age at presentation, 17.5 months. They have family history in 48 patients, but they have high consanguinity rate of 58 patients. They are consanguineous. 60 patients present with hematuria, 23 patients present with renal failure at presentation, 47 patients, they have hypothyroidism at presentation. 24 of these patients present as congenital nephrotic syndrome, 9 patients as infantile nephrotic syndrome, and 44 as childhood nephrotic syndrome. This diagram shows us the histopathology. Diagram A, the histopathology of the patient. 44 patient biopsy was not done. 40 patients, they have focal segmental sclerosis. 6% they have congenital nephrotic phenotype, and the other one they have diffuse mesangial sclerosis, minimal change disease, and interstitial fibrosis. And the diagram B shows us the genetic. The most common gene in these children is NPHS2, then NPHS1, but we have few patients, 8 patients with laminin beta 2 in 2 patients, phospholipase C epsilon in 3 patients, Mayo 1E in one patient, and UP93 in two patients. There were 17 patients without diagnosis. Only Sanger sequencing was done, and 2 of them, they have whole exon sequencing. This table summarized for us the clinical follow-up and treatment of the study cohort. So the mean follow-up, it was 59 months. Immunosuppressive was given to 25 patients. Kidney failure requiring dialysis was done for 45 patients, and 70 patients had kidney transplantation. So the conclusion of the study, NBHS2 and NBHS1 gene mutation were the most common genetic cause of steroid resistant in Omani children. Using WIS increased the rate of mutation detection in other genes responsible for steroid resistant nephrotic syndrome. So screening for genetic etiology in all genes responsible for nephrotic syndrome should be implemented in all patients who are presented with steroid resistant nephrotic syndrome. This is going to help in management decision and genetic counseling. The take-home message: steroid-resistant nephrotic syndrome represents management challenge. The genetic of steroid-resistant nephrotic syndrome is expanding. To improve the detection of the gene associated with steroid-resistant syndrome, we have to use modern next-generation sequencing like target gene panel, whole exome sequencing, and also whole genome sequencing. Such strategy of this diagnosis going to improve our understanding of etiology of steroid-resistant nephrotic syndrome, also enhance personalized medicine in the term of individualizing management, and also to avoid immunosuppressive medication in these patients. Thank